Hi, my name is Megan Lear, and I work with the team at UMHS putting together these live stream events for current and prospective students and people in the medical community. And during our last live stream event, where we featured recent graduates who were in their first year of residency, we had a lot of questions for one of our panelists, Dr. Kaiser, who is practicing in Canada. And so we decided that since there was so much interest, we'd put together a panel tonight featuring two UMHS alumni who could talk about their experiences of going to school at UMHS in St. Kitts and then practicing medicine in Canada. So I'd like to introduce our two panelists tonight. And I'd like to start with Dr. Bremner. Dr. Bremner, sorry, go ahead.
So I'm Dr. Bremner. I currently live in Belleville, Ontario, and I work in Trenton, which is the next city over, and it's the largest airbase in all of Canada. I work in family medicine. I do both clinic and hospitalist medicine. And right now I have about a panel of 800 patients in the clinic. Yeah.
Perfect. Thank you. And Dr. Khan, welcome. Do you want to tell us a little bit about your practice and what you do?
Sure, yeah. So I currently live in Vaughan, Ontario, and I have a practice in Bolton, Ontario. I do family medicine as well. My practice, I am starting from scratch, so I'm renting space in another clinic from another doctor where I use his equipment and his staff, but I have my own patient panel and just been accepting new patients. And I do general family practice, a lot of female visits, a lot of children immunizations. I do some procedures in the clinic too, like biopsies and stuff like that too.
Perfect. Thank you. And just a quick housekeeping note, just wanted to let everybody who is tuning in to submit your questions to the chat on whatever platform you're using. We'll be monitoring your questions and pausing throughout the live stream to respond to your questions. And then we will also have a Q&A at the end. So any content that we didn't cover, any questions we didn't answer, you will have an opportunity at the end of the talk to submit additional questions. So thank you so much for joining us. Just kind of starting at the beginning, wanted to talk a little bit about why you chose UMHS. What was it about the school you liked? And we can start this with Dr. Khan.
Yeah, so I chose UMHS because I had heard about it. So what happened was I was in the pre-med club in my undergrad, knowing that I was interested in medical school at the time. It's really hard to get into medical schools in Canada. There's not a lot of opportunity. So I was kind of looking elsewhere and seeing what was out there. And UMHS was one of the most proactive schools. So I saw them come and give us a talk. They reached out to us as a pre-med club to come give a talk at our school to tell us about the medical school, the facilities and all that kind of stuff. And I really liked what they were saying. And so I decided to apply.
Perfect. And Dr. Bremner, do you want to tell us a little bit about how you found out about UMHS and why you chose UMHS for med school?
So similarly, like it's very, very difficult to get in Ontario, and I had a feeling I wasn't going to get in. And one of the doctors that actually worked in our clinic at the university where I did my undergrad was actually a graduate of UMHS. So that was kind of the first I had ever heard about Caribbean medical schools and things like that. And then every year we had kind of like an on-campus job fair, and UMHS had actually come, and that's like the way I heard about just like that specific Caribbean school. So I was interested in learning more, and I wanted to make sure, like, is there a way for me to be able to come back home and practice afterwards? So I was going to school in Oshawa, so I made the trek to Toronto one day, and Michelle Perez was putting on like an information session. So I met her, I met a couple of the students at this session, and I just felt really comfortable, and it seemed like a really good fit for me. And it was the only school I applied to, and thankfully I got in, and the rest is history.
Perfect. Thank you. And we can start with you, Dr. Bremner, but what kind of support did you feel like you received at UMHS as a Canadian medical student?
So before going to the island, I had never even got on a plane before, let alone just packing my life into a few suitcases and flying all the way to St. Kitts. But the biggest thing for me that made me feel like welcomed and like I was fitting in, or gave me some form of direction on how do I study, because the way I studied in medical school was totally different from how I studied in undergrad. And there was I'm sure it's still there, a mentorship program. So my mentor was actually probably in the same class as Dr. Khan. So she kind of like took me under her wing and gave me all kinds of like study notes and videos, and was like, hey, like for this class you really need to do this, and like for this class you really need to do this. And I just felt like instead of trying to like scramble and figure out like, oh my goodness, what am I doing, and I'm living like in the Caribbean, like super far away from everyone, I felt like that was super helpful for me.
Perfect. And I know when we spoke earlier, you had also talked a little bit about how you appreciated meeting all different types of people when you were on the island, and throughout your experience, how that kind of helped better prepare you for your medical practice. Just wondering if you wanted to say anything about that or not.
So I think like a great thing looking back on it, I moved a lot throughout my clinical rotations, but I wouldn't trade that experience for anything, because I was able to live in so many different parts of the States. I was able to interact with so many different cultures. Of course, kind of like the culture on the island, dealing with like the native St. Kitts people. I just feel like I was able to kind of take everything that I've learned from dealing with people from all walks of life. And then, of course, in medicine, you have to be good at talking to people. So you just learn to really like appreciate different people's like cultures and kind of like thoughts about different things.
It's pretty brave to hop on a plane and go halfway around the world to go to medical school. And Dr. Khan, I think you had a similar experience. Do you want to tell us a little bit about the kind of support that you got while you were at UMHS?
Yeah, sure. Yeah, similarly, I also, it was my first time on a plane. I hadn't really left Ontario at that point. I mean, even when I first got there, it was nice how there was like the welcome committee that brings you onto the island and kind of takes you to your place, because my luggage got lost, and they were able to help me organize all that because I didn't know what I was doing flying for the first time. So, I mean, just right off the bat, it was already like there was lots of there was volunteers, students, and then the staff that works at the university that was really helpful. But then going on to studying and having the teaching assistants and the available to us for each of the courses that we were doing. So they kind of gave you an idea of what you need to be doing to study and that kind of stuff. I liked going to those extra TA sessions, and I really liked that the professors had basically open office hours. They were mostly there to teach. So if I ever had any questions or if I ever wanted to talk to them, all I had to do was go and see them. So it was really supportive in that way.
And I know Dr. Bremner was talking a little bit about how she worked with her mentor to learn how to study and be very prepared. And I think Dr. Khan, you had mentioned something about how the basic sciences program provided you with a solid foundation. I was wondering if you wanted to talk about that a little bit.
Yeah, for sure. So very similarly, I did not study the same way as I did in med school. So after going through and seeing how the questions were, and because a lot of the professors will show you what the questions look like, how you should be prepared to study for them and that kind of stuff. So going through the basic sciences and understanding really what exams are expected of you, what exams are expecting of you, and how questions are worded and how they're asked so that you know what they're looking for so that you can actually answer them appropriately, not just knowing the knowledge, because there is a skill to answering questions as well. It really prepared me for all the USMLEs and even the Canadian exams on top of that.
Thank you. So I know that you had both mentioned that you went to medical school with the intention of returning home to Canada and practicing medicine in Canada. So just wanted to know if you could elaborate, Dr. Khan, a little bit more about what your expectations were for returning to Canada after graduation and what might have made your path a little easier.
Yeah. I did know that coming back to Canada can be difficult if you want to go into specific specialties. There's a very high demand for family physicians and general practitioners in Ontario. So if you went to study abroad, it was promoted by Ontario itself, and they wanted you to go train and then come back. So I knew it was possible. And then I started looking into what would be required. So you need to have like a physician supply account and that kind of stuff. So making sure I kept on top of all of that, because as you go through the stages and you're taking like the USMLE, you're applying for the next steps and all that kind of stuff, there's also things that you should do in the Canadian system to go along and to make sure you're keeping up with that too. So setting goals and making sure you're keeping up in both countries so that you can try to come back is sort of how I kept track of what I was doing in order to be able to return.
Perfect. And Dr. Bremner, do you want to talk a little bit about your expectations for returning to Canada?
So it was always my goal to come back home, but I didn't know how to get there. I just kind of like took everything as like one step at a time. So I applied for residency both in Canada and the US, and I ended up matching in the US. So then about halfway through residency, I knew for sure I was very hard set that home was where I wanted to be. Even when I left Louisiana, and when I finished my residency, I didn't really know like how to accomplish it. But once I got home, I made it my mission to figure out all of the paperwork, all of kind of the long drawn out process to get a license here in Ontario. But I knew for sure there was a way to do it. You just had to figure it out. And that's why I just want to try to help people as best I can so that people don't feel like they have to stay in the US because that's where they did their residency, that you can come back home if that's what you want. And not to give up on that dream.
Perfect. And it looks like we've got a question in the chat. I'm starting my journey in St. Kitts in September, wondering if you could speak to your experience with CARMS. Dr. Bremner, you're nodding, do you want to respond?
Sure. So with CARMS, so for people who are unfamiliar with that term, so it's the Canadian Residency Matching. So it's similar to ERAS in the States, which is how you match into a US residency. So as I went along, I was completing my Canadian exams kind of at the same time as my US exams. So I tried to plan there was a written exam that you used to have to take to apply to residency in Canada that is no longer. But I timed that exam with my Step 2 CK because it's pretty much all the same clinical knowledge. So I tried to align all of my exams at the same time. And then with CARMS, it's a little bit different than when you apply for residency spots in the US. So in the US, everyone's kind of on a level playing field. So regardless of whether you're an IMG or a US grad, you all apply to residency spots. In Canada, we have reserved spots that are for Canadian citizens who trained abroad that you can only apply to. You can't necessarily apply to spots that are reserved for Canadian trained grads. I applied to 38 different programs, and in the States, I think I applied to like 160 something. I didn't get any interviews in Canada the first time around, and then I went for like the second iteration. So there's actually a lot of unfilled positions in Canada, particularly in rural areas, if that's your interest, because most people want to stay in urban areas. So if you're looking and you'd be willing to go to a rural area, those are the better areas to apply to. I did get a couple of interviews in the second iteration, but because it falls at the same time that the US match happens, you can't double dip. So I matched in the States, and then I had to actually call and decline my interviews in Canada.
So that actually brings up a good point that someone else is asking about in the chat, which is, what are the main pathways to practicing in Canada? And Dr. Khan, I know that when we spoke previously, we talked about kind of two different pathways. So I was wondering if you could talk a little bit about like doing the residency in the US as one pathway and taking the certain exams to go right into practicing in Canada. Would you be able to respond to that?
Yeah, sure. So the pathway that I took is I did my residency in the United States. I didn't apply to CARMS at all, so I only applied to residency in the US. What I did then is knowing that I was going through residency there and getting licensed in the state of Iowa where I was practicing, what I had to make sure of was making sure that I took the Canadian exams that were required and that I completed all the account expectations that they had as well. So specifically, we need to have an account for physicians apply. And there's then it's changed since I did it. So it's not exactly the same. So I did the MCCEE at that time. Now the expectation is only to do the MCQE1, which I also did. And then there's the MCQE2 that I did that is no longer required anymore either. So it's really only the MCCQE1 that anyone that wants to come back to Ontario specifically needs to do in order to come if you complete your residency in the United States. I think the alternative pathway that we were talking about is doing your med school at UMHS and then applying to CARMS and just doing your residency in Canada that way. I don't know the pathway very well for that, but there are specific exams required for that as well.
So this would probably be a good time too to put in a plug for the UMHS academic and student affairs. I know Patrick McCormick and his office is ready to respond to specific questions and help Canadian med students at UMHS kind of navigate the different pathways to practicing medicine in Canada. So we just wanted to make sure that we get his contact information out and that you can direct specific questions. They'll be happy to work with UMHS students to help kind of navigate those different pathways. And I know there's a couple questions in the chat about, let's see, about billing, which I know that we had talked about. Dr. Bremner, I know that when we were talking in our call ahead of this, this event, you were talking about different rotations that you did in Canada and how you learned a little bit more about billing during your rotations. I was wondering if you could talk a little bit about that and maybe respond to the question about learning how to do billing.
So because finances were short, and I didn't live near like the GTA area or where there were some of the training schools, the only rotation I did in Canada was at Ontario Shores in Whitby. So we have a partnership with, it's an inpatient psychiatric facility that also has an outpatient clinic attached to it. So I was home for those 6 weeks to do that rotation. I did not, except for like, of course, growing up in Ontario and going to the doctor, I didn't know a lot about the healthcare system in Canada from like a physician standpoint. So I felt like that kind of really opened my eyes. And also having trained in the States, it kind of allowed me to contrast and compare the differences and similarities between the two. Now, when it comes to billing, I absolutely had no clue how to bill when I came back home. So we learned how to bill in residency because, you're closing your own charts and things like that. Billing in Canada is so much easier than in the States. One of my colleagues sat me down, and within 2 hours, I had the hang of it for all of my inpatient billing. So for working in the hospital, there's actually very little codes, except for there's small little nuances like here and there. Like if you have a super sick patient that is requiring like ICU level care and you're taking care of them until you get them to where they need to be. But it's not something to be like afraid of or scared of. It's very straightforward. In the clinic, similarly, there's like a little thing you can order from the OMA, which is the Ontario Medical Association. It has every code pretty much that you would ever use. And it's way more straightforward. Like in the States, there's kind of these things called modifiers. Like if you do like one-sided joint injection versus two, whereas in Canada, it's just like you just drop the code and how many quantities of them. And the likelihood of your codes being rejected or kicked back is, again, pretty much slim to none in Ontario. They kind of trust that you're billing it unless you do something sketchy or like your timeline is not adding up. Like you're saying that you saw 20 patients in the morning and you did all telephone visits and they were 20 minutes a piece, but you've billed for more than that. That's really the only time you're ever going to get audited.
And it looks like there was another question, Dr. Bremner, just to kind of follow up, because I think we had spoken specifically about this too, where you could talk about a pathway 3 or 4, where you do 1 year of supervision in your field of interest and are not required to take Canadian exams. Can you touch on that a little bit?
Yeah, so because, so Dr. Khan was a little bit ahead of me, so she can speak to kind of what happened with her, but we were sitting around waiting forever, basically, to take this exam that got postponed because of COVID. And I just kept waiting. And then they ended up canceling the exam. So I never ended up having to take it. But I initially actually applied for what we call a restricted license in Ontario, where I would have had to have been supervised. And then thankfully everything worked out and I ended up with an independent practice license. But there is a way that you can work supervised for 1 year without taking the QE1. Now, I would advise taking the QE1 because now that that's the only exam that you actually have to take to come back. If you've passed step 3 in the States, you can pass QE1. And you, as the supervised thing, it's like I see why some people do it because it allows them to like better adjust to how to practice medicine back home and things like that. But if you've completed your residency in the States, the medicine is the same. It's just the small little nuances like how to bill or who are the specialists in my area that I need to be referring people to, which your colleagues can help you with figuring that out. When you are supervised, you have to be very careful where you go. So there is actually a service in Ontario that helps try to connect you with communities, but a lot of them are actually up north because, of course, they're areas in dire need and they want to pull you there. And they sometimes require you to have a return of service. So you may have to remain there for 1, 2, 3, 4, 5 years. And then you actually basically have to pay your supervisor a good portion of the amount of money that you're billing every month. So depending on the model that you're practicing medicine, the few $1,000s it's going to take you to do your exams and make your physician supply account and get all your documents uploaded, it's worth it to just take the QE1 and then get your independent practice license.
Perfect. Thank you, Dr. Khan. Did you want to talk to a little bit just about how you prepared to return to Canada and maybe some of the rotations that you did to prepare you?
Yeah, sure. So I did. So I did go to Ontario Shores as well. So I did their psychiatry rotation in Ontario through the affiliation that we have with them. So I mean, that's one of the things that did help prepare me. And something that prepared me even more was at the time, the University of Toronto had a lottery system where you could apply to try and get a rotation in Ontario in a specific field. So I applied to try and get a family medicine rotation, and it's just sort of picked at random. And so I did get a rotation in Mississauga, pretty close to my family. So it was really nice to be at home, but it was also nice to learn specifically. I was just one-on-one with that doctor. He kind of showed me exactly what he does, how he practiced, and actually was a lot more hands-on than a lot of the rotations I did in the States, where I was able to like give all the vaccines myself. I was able to do the procedures in the clinic and that kind of stuff too. So part of that's really solidified me wanting to come back. And I did keep in touch with him too. So every once in a while I would ask him for advice and help and stuff like that for quite a bit of time. So it does help to know people and try to explore. I know the lottery system doesn't exist, but there are things that do exist and they do change a lot, I've noticed. So like the universities will come up with different ideas of what they think would be a good idea for med school rotations and stuff like that. So just keeping on top of it, like just checking their websites and seeing if there's anything coming up where there might be an opportunity for you to come back and do a rotation in Ontario somehow, some way. There's often a chance.
Perfect. And could you, this is a nice little transition for us, and we can start with you, Dr. Khan, just to tell us a little bit about your residency and your experience after graduation.
Yeah. So I went to Northeast Iowa Family Practice Center in Waterloo, Iowa. So I, sorry, what was the beginning of the question?
Just to tell us a little bit about your residency experience.
Sure.
So.
Okay. So it was a lot of inpatient and outpatient both. It was a good mixture. Our program was unopposed. So we kind of had the hospital to ourselves. There was no other residency programs, no specialist programs or anything like that. So we worked with everybody. So when we did rotations, we were one-on-one with those doctors as well, not really like with other residents that were doing those specialties and stuff like that. So there was an open ICU. So I learned how to do intensive care. I learned how to do emergency medicine. I learned how to do procedures in the clinic. That's where I became more confident to be able to do that in my clinic myself now. And then there was clinic itself that we did a lot of too. Progressing throughout the years, I was really proactive in my residency. I wanted to learn what was good about practicing in different ways and what wasn't. And so I tried to make changes. I became the chief resident. I looked at what we were doing well in the clinic or what we weren't and tried to find better ways to do things so that I could take that back with me and practice it when I come back here. I also started doing a little bit. I had friends that were ahead of me that came back to Canada. So I started looking at what they were doing in Canada, what was different between the US and Canada, seeing what worked and what didn't, so I could try to incorporate it and do things the way I wanted to when I returned.
Perfect. And Dr. Bremner, could you just tell us, I know you mentioned where you did your residency, but maybe talk a little bit more about your experience during your residency?
So I did my residency in Bogalusa, Louisiana. So it's about an hour and 15 minutes northeast of New Orleans. It's an LSU program. It's their only rural family medicine program. So I specifically was hopeful that I would end up in a rural program. Similarly to Dr. Khan, our program was unopposed. So we had full run of the hospital. Our program was fairly heavy on inpatient medicine. So in our first our first year, we did 6 months of inpatient medicine. And then it kind of decreased with time. And so in the height of COVID, of course, like we were intubating people like crazy. You know, a third of our patient list was all ICU. So excellent for learning. And then in our clinic, because we were basically serving a population that was about 85–90% Medicaid, to get patients to specialists was very limited. Our population was extremely poor. The average combined household income was only $32,000. So the difficulties with getting people down to New Orleans for specialists. So we had to kind of take on a lot of different hats. We didn't have a lot of specialists to pull from at our hospital either. So we did a lot of course, joint injections, things like that, that you would normally might see sent off to ortho if you were in a more urban setting. We did all of our own biopsies. And then there were a lot of other specialists that we had the opportunity to go out and work with if they weren't at our hospital. So I was at a Catholic facility, so I wanted to just try to make as many opportunities. And I really thought about, I used residency, like what Dr. Khan was saying, to learn what I did want to do and what I didn't want to do. So I, for instance, wanted to learn to do IUDs. So I went down to New Orleans, made sure I was competent in that kind of stuff. So would never ever trade my training for anything, because it was a difficult 3 years, but when I left, I felt very competent and like I could go out and practice on my own.
Perfect. And we do have a couple of questions from the chat. This seems like a good time to bring some of those in. And Dr. Bremner, I think you answered this when we spoke previously, but maybe you could respond to this question about when should students take the MCC QE1 relative to the step 1?
So you would want, I think timing wise, you would want to be kind of nearing, I think you actually have to be in the last, I can't exactly quote it. I think you have to be within the last 14 months of med school to even be eligible to take QE1 or something like that. I don't think would succeed very well if you took it with step 1. So in Canada, we do not have an introductory exam prior to going out to your clinical rotations, the same way that you do in the States, like what step 1 serves as. QE1 kind of is more along the lines of step 2 CK, with another little nuance. When you take step 3, which most people take in residency, there's kind of a clinical application component. So I feel like you probably wouldn't be ready to take QE1 until nearing the end of medical school, or if you knew you were going to go to the States for residency, then taking QE1 around the same time as your step 3 would probably be helpful.
Perfect. Thank you. And I think too, just because there have been some changes since you were at UMHS, it's probably a good time to put in the plug again for Patrick McCormick and Academic Affairs to help with specific questions. Dr. Khan, there was also another question that came in that maybe you could respond to. that if you're successful in your transition back to Canada as a physician, are there opportunities for fellowship training available? Are you considered a Canadian applicant? Could you respond to that question?
I'm actually not sure. I didn't look into it at all. I didn't want to specialize beyond family medicine, so I'm not sure.
Okay, Dr. Bremner, is that something that you'd be able to respond to?
So I looked into it because the only thing that I thought I would be willing to do a fellowship in would be geriatrics. And I considered it because I knew there was going to be a waiting period between finishing residency and getting my license in Ontario. It does not further you in terms of getting your full independent practice license, because even if you do a fellowship, you're still considered an international medical grad. So you still have to take like QE1 and fulfill a few other kind of loopholes. They don't just kind of like wash it under the rug that you are an IMG and you trained abroad, and then just because you did a Canadian fellowship, you still have to do all the other extra added paperwork to get your independent practice license. So I didn't do it.
There's another question in here. Why do you apply to so many residency programs? Can you talk a little bit about the residency application process? I don't know if Dr. Bremner, you want to respond to that one again, or?
Sure. So as an international medical grad, you're not only competing with other international medical graduates, but you're also competing with either US trained grads or Canadian trained grads, depending on whether you're applying in the US or in Canada or both. So it is a little bit of an uphill battle. There's, of course, more applicants than there are spots. So you just have to make sure that you cast a wide net and that you don't pigeonhole yourself, because it can be really tough if you do not match, because the further out you get from graduation, the more difficult it becomes to match, because it's hard to stay like clinically relevant and prove that to residency programs. So you just want to make sure that you're maximizing your opportunities, and that you're keeping a very open mind as to where you go, because ultimately at the end of the day, if you're in the States, ACGME, so the accrediting body for residency programs, everyone has to meet the same expectations in residency. So you'll still get the same core like basic training. So just have an open mind. You may have to move really far away from home to complete your residency, but you need that residency so that you can get board certified, so that you can get your license, so that you can go wherever you want to go.
Perfect. Thank you. And Dr. Khan, I'm going to direct this question to you. Any insights you can share for current students looking to eventually practice medicine in Canada? I know you had talked about a lot of opportunities for family medicine. Just wondering if you could talk a little bit about like planning for licensing exams and so forth.
Yeah, sure. So when you're looking to come back to Canada, it's kind of important to keep track of what's going on in timelines. So thinking about the exams that you do need to take, there's a lot more restriction compared to the US. So like when you're taking the US MLEs, you can take them pretty much throughout the year. The MCCs and the MCC QE1 is only going to be offered at specific times frames. So you need to be watching out for that, trying not to miss the window, because if you're trying to get things done in a certain time frame, then you need to make sure you're doing them on time. And similar to what Dr. Bremner was saying, doing it with step 3 is probably how I would go about doing that. I feel like using the MCC website is very useful. They always keep updating it with timelines, what's expected. There's sections for international medical graduates and what you need to be doing to come back. Also, similarly with the physician supply account in their web page, and making sure you already have that account started, so that you have all the information, because when you first start out creating that account, they're going to ask for a lot of identification, proof of the med school you're going to, several things. So keeping on top of the paperwork so that you know that you have everything ready and set up when you do need to sign up for the exams. Other than that, I'd say that those are the most important things for coming back to Canada.
Perfect. And Dr. Bremner, did you want to add on to that?
Just as Dr. Khan was saying, so like in Physicians Apply, there's something called a source verification request, but basically if you have any piece of paper that you are trying to prove yourself as to who you are, it takes like 3 weeks now to get it approved. So you just want to make sure that you kind of have your ducks in a row and that you're planning ahead, because if you're waiting on like one piece of paper that's hanging you up from being able to sign up for an exam, you don't want to miss the window because of that. So as soon as you create that account, anything you can upload, you should go ahead and do, because it will take a little while to get it all pushed through and approved.
I can add some more. They're really helpful. So if you don't know what you are expected to have for certain exams, and you just ask Physicians Apply, just email them and they'll give you a list. It does take a long time for them to get back to you, so make sure you ask them early if you need to.
Sounds like good advice. And then there's another question in the chat, and either one of you can just kind of raise your hand and say if you want to take this one. But how do you go about getting a rotation in Ontario? Who do you speak with?
Okay, so I did a lot of that.
Okay.
I mean, so for as far as the ones through Ontario Shores, anyone that's at UMHS can do that. You just kind of organize that through Patrick McCormick. They'll help you organize those rotations. Making sure you do plan ahead, because I wasn't able to do the family medicine one because I believe there was a wait list and you had to be on it for quite a while. I'm not sure if there still is, but there was when I was there. So planning a little bit ahead and looking into it before you get to that point where you want to be on that rotation. Like I mentioned, I did the University of Toronto's lottery. So going to various universities' websites for their medical school pages, they'll list off rotation availability and whether or not they accept international medical graduates to do rotations at those places. I didn't do this, so I don't remember what it's called, but I know there is a way to sign up for a paid program that helps you do rotations in Ontario as well, if you want to go that route. Once you do organize them, all you have to do is let the school know that you organize this rotation and the dates that you're going to do it so that they can add it to your schedule.
Perfect. The next thing that I wanted to talk about, just because we've talked a lot about your path to UMHS and your residency programs and getting rotations, just wanted to kind of shift a little bit into describing what your current medical practice looks like in Canada, just sort of a day in the life, the type of patients you see. So Dr. Khan, can we start with you on that?
Yeah. So I mostly am 9 to 5. There's some days that I stay later until 7 at my clinic. So right now I'm doing just clinic. It's just all outpatient. Because I'm new, I am accepting new patients. We do a thing called a meet and greet often in Ontario, where you have new patients that are looking for a family doctor come in and you just sort of get to know their entire medical history. And so I do a lot of those recently. And then pretty much do everything a family medicine doctor would do in regular clinic visits. So going through different issues, medical history, and whatever their concerns are, and addressing whatever I can, referring when I can't. I do procedures, as I've mentioned before. So I do skin biopsies. Usually I make these the last patients of the day. So usually the last patient of the day is either some sort of procedure. So a skin biopsy. I do a lot of birth control implants. So the arm implant, I do a lot of those. And I do once in a while joint injections as well for arthritis. I see a few walk-in clinic visits in between throughout the day, so acute things, so fevers, coughs, colds, that kind of stuff. Um, and typically, I was originally, when I first started and was very new and accepting patients, I was seeing maybe only 3 or 4 a day, but now I'm up to about 30 to 40 patients a day. So it's a kind of a very rapid pace, another patient every 10 to 20 minutes, depending on what the visit is for.
Perfect. Thank you. Dr. Bremner, do you want to talk a little bit about your practice and maybe a little bit of a day in the life?
So I do both clinic and hospital medicine. So in the hospital, I'm on, our hospital weeks go from Tuesday to Tuesday. We switch over at 5 p.m. in the afternoon. That way it allows us to be in clinic during the day leading up to us taking over for the hospital. And in our clinic, which I'll speak to my model, it's a little bit different. A lot of my colleagues help to cross cover me. So the week that I'm in the hospital, I'm not trying to bounce between clinic and the hospital patients. So as a hospitalist, I'm responsible for, when I come on a Tuesday afternoon, getting to know all of the patients that are already admitted. And then as people come into the emergency department, if they are sick enough to need to stay in the hospital, the ER physician calls me to admit them to the hospital. So I go down, get their story, decide what do we need to do to get this patient better while they're staying in the hospital. I do their history and physical, and then I keep them there until they're ready to go home. So I'm also responsible for each day reevaluating patients as to whether they're ready to leave. So we only have one hospitalist on at a time. On average, we have about a 25 patient census. Historically, our hospital has been kind of more older individuals awaiting to go to long-term care or maybe a retirement home or things like that. But lately, we've been getting a lot of acute patients. And I work for a healthcare corporation, so there's 4 hospitals under that umbrella. So if I need to get a patient to a higher level of care, because we do not have ICU beds at our hospital, it's just a general medical surgery floor. So if a patient, let's say, needs to get intubated or is on BiPAP, then I transfer them to the intensivist under our corporation, and they just accept them. Unless they don't have any beds, then I have to call outlying facilities. But usually 9 times out of 10, I just ship them to Belleville. And then in the clinic, I am part of something called FO, which is a family health organization. So instead of just billing OHIP for every patient I see, I still do that. It's called shadow billing, but I only get about 3% of those billings. There's certain things like joint injections or IED insertions that you get paid for above and beyond, but I'm on a capitation model. So basically, I was transferred patients by the Ministry of Health that now are rostered and belong to me. And then every month, the Ministry of Health just pays me basically a set amount based on the number of patients I have. So regardless of like a 15-year-old, which you may see like once in a blue moon, I'm getting paid regardless of whether I see them or I have a patient that in 2 weeks I saw 3 times. So I'm still dropping the charges like in the background, but basically I'm just getting paid like a flat rate. And then the odd thing here or there, like I did a toenail removal, and I think that earned me like maybe $76 or something like that. So there's little things here and there that you can make money outside of what they call the basket.
So that kind of brings up a good point and something that you mentioned in our earlier call, where there's a misperception that if you go back to Canada to practice, that you'll make less money than if you stay in the United States. And Dr. Bremner, you kind of dispelled that myth. I was just wondering if you could talk a little bit about that.
So it totally depends on the way you practice and how you do it. So if you join a FO, because you're on that capitation model, you have that guaranteed income every month. So if I took that money plus what I'm earning from the hospital, once I fully have all of my patients rostered, if I was comparing to where I was doing practice in residency, even with the conversion of the US dollar to Canadian dollar, I'm making more money here and I have a way better quality of life. So why wouldn't I come back home? But for someone, like for instance, Dr. Khan can speak to it, when you're on like a fee for service, so you're billing for every single patient you see, and that's where your earnings are coming from. So that's how I make money in the hospital. It can, you of course have to see more patients to be able to make more money.
Did you have anything you wanted to add to that, Dr. Khan?
Yeah, sure. I mean, I can say like I'm doing a fee for service model. So it does, so every patient I see, I bill for. So I only get paid for what I did exactly for that person. So I don't get the sort of the same kind of compensation the way Dr. Bremner would. So the more patients you see on a fee for service, the more you're going to get paid. The more procedures you do, the more you get paid, because procedures you can bill higher for. And then depending on the types of visits, you get paid different amounts. A little bit of it depends on the length of the visit as well, and whether or not it's over the phone or in person or virtual. So it can vary dramatically. Sometimes I know for a little while, our clinic was under construction for a short amount of time, and we were doing just virtual visits for about a week. And so during that week, my billing was significantly less, just because I don't have that coverage where that a FO has, where you have patients assigned to you and you're being paid for having them under your roster. So I don't really have a roster, but I do have patients that are specifically mine.
Perfect. Thank you. And just, I'm going to pause and look at a few of the questions that we have in the chat. And one of them I know we had talked about. So you can, either one of you can just sort of raise your hand and say who wants to take the lead with answering this question. But have patients ever asked you about how you know about practicing medicine in Canada since you did your medical education in the Caribbean? How do you respond to people who question your experience or expertise coming from a Caribbean med school?
Yeah, I mean, I can answer that.
Great.
It does happen every once in a while. It's not as often as you would think. Most people just think, oh, neat, you went to the Caribbean, how interesting. And if you tell them a little bit about it, they think it's a great story. Every once in a while, you do have people that wonder whether or not you know what to do in Canada. And the thing you can reassure them about is medicine is the same. We're not practicing anything really different. I mean, what we're trained on is what we're trained on, and we know what to do. The only thing we may or may not know is resources in the area, maybe protocols in that specific area or something like that. But really, you catch on really quickly. And so like within a couple months of practicing, checking in with colleagues about anything you don't know, you'll figure it all out. And you can even be very honest with a patient. If you don't know something, you just tell them, well, this is not something I've done in Canada yet. I know the process, but not specific to Canada. So I'm going to speak to my colleague and get back to you. And usually that's enough for a patient, because they know that they're being taken care of. It's not like you're just going to leave them and not ever complete whatever they needed to have done. So.
Perfect. Dr. Bremner, was there anything that you wanted to add to that?
I think like eventually once you graduate and you've completed your residency, most people just assume that you have adequate enough training. Like if you're licensed in Ontario, you obviously have to have done something, right? So I found more like in medical school, sometimes people would question like, oh, you know, are you getting like the same education being in an IMG? But I think that ultimately looking back on it, it made me a way more well-rounded person. And I think I learned more. And then having done my residency in the US, it was 3 years, whereas you only do 2 years here in Canada if you're in family medicine. So I think ultimately I came out actually better trained than if I had stayed here. And no one really has really questioned me since I've gone into independent practice.
So, Dr. Bremner, you touched on a good point and something that I think people are curious about, and that is what are some of the key differences between practicing medicine in the United States and practicing in Canada?
So in the US, because everyone has what we call a different payer source, so you have private insurance that reimburses you. So depending on who the insurance company is that's paying you, there's good insurances, there's bad insurances, and sometimes they don't like to pay for things. So there's a lot of paperwork in the US to get things approved. You have to be very, very specific in your documentation, the things that you're writing in your notes, for instance, to get an MRI approved. You have to have like a checkbox of things like I've done XYZ before I ever got this approved. And then a medication that may be paid for one person because they have X insurance might not be paid for someone who has Y insurance. And then for where I trained, because the majority of my patients were Medicaid, getting them to specialists was quite challenging, because a lot of specialists don't take Medicaid because it doesn't pay very well. So there's like this misnomer that you wait forever and a day to get into specialists here in Canada, which is very dependent on what province you're in and where you live, because of course there are more specialists in urban areas than there are in rural areas. So like where I live, you're going to have to travel at least an hour to go see a neurologist or things like that. But there seems to be this like thought that, oh, you're going to wait like a year to get an MRI on your knee. Like I have a portal where I order all of my tests and it gives me expected wait times. And depending, it like sometimes takes about like 2-ish, 3-ish months, but because everyone's on a level playing field here, because we have what we call OHIP here in Ontario, so that's our health insurance. It doesn't matter whether you're like some big business banker or if you're this homeless person, you're in the same waiting line. So everything's triaged. It's a far more level playing field, and it seems like a lot more fair. And you don't have to justify yourself to get things approved. And there would be a lot of medications I would write, and then the pharmacy would like kick it back. And there's something called like a limited use code here in Ontario, and you literally just put that on the prescription, and no one's ever going to ask you again. Like you might get asked it again like 5 years from now, but getting things approved and the amount of documentation is way better here.
Perfect. Dr. Khan, did you want to add on to that? I know you talked about cancer care in Canada and routine screenings. Maybe you could talk a little bit about that.
Oh yeah. Yeah, so everything is very standardized here. So I know like specifically where I was practicing, we individually as doctors had to keep track of our screening that we were doing for patients. So PAPs, mammograms, colonoscopies, knowing what was due. So if you didn't have good documentation, if you didn't have a good medical record system that helped you keep track of when things were due for patients, that you'd have to be looking back in a lot of things to figure it out. Whereas in Canada, because it's universal health care, it's kept track of through your health card that you have. So the government knows when you've had your last PAP, and so they send you a letter in the mail saying that you're due for your next one, and so they just come to the doctor and say, well, I'm due for this. So it's a lot less missing of screening tests. So making sure everyone's up to date with screening and preventative care, which I really enjoy doing, a lot of preventative care. So I like that it's simple.
Perfect. And just a few more questions from the chat. And again, you can just sort of raise your hand or jump in if you're eager to respond to this one. Did you have a gap between the end of your clinical rotations and your residency? And if so, what did you do during that time period? Any suggestions for students in that situation and what they can do? Do either of you want to take that one?
We can.
Okay, great.
Yeah, so I had a gap. I graduated in September of 2016, and I started my residency in July of 2017. So during that time, I was back in Ontario. It is, for me, I mean, for me, it was kind of difficult to try and figure out what I wanted to do, because I didn't want to do anything where I would be starting some sort of research job and then leaving it right away. So I did a lot of volunteer work. I was volunteering for Erin Oak. It's a center for children with disabilities. So I did like their swimming program, their ice skating program. I also volunteered at a diabetes clinic. And that actually, the diabetes clinic was really good because volunteering in a clinic actually helped me see how healthcare is run in Ontario. So I kind of saw like the behind the scenes, the admin side, because that's where I was volunteering. So I saw how the appointments were being scheduled, what the routines look like for diabetic care in Ontario, which, I mean, no matter what family doctor you are, you're probably going to see a lot of diabetes in your time. So I found it really useful to figure out those resources early on, just because I happened to be volunteering at a clinic that did them.
Perfect. And I think, Dr. Bremner, I think this was something that you referenced. There's a question about, you were talking about IMGs, having to do your residency in Northern Ontario. How far north would that be, please? Is that something you could respond to?
So with regards to the positions about Northern Ontario, that's if you want to do a supervised year. If you did not want to take the QE1. And when I say Northern Ontario, I mean Northern Ontario. I mean like Thunder Bay, like Moose Factory, places that you have to like fly into sometimes with a plane. So that's where, and it really depends. So for instance, Campbellford, which is probably 35 minutes northwest of here, they are so desperate for physicians that they're actually on this same portal for Trent Hills that they're trying to try to obtain doctors to come work there because they're on the verge of basically shutting down. But that's specifically for the areas that if you were going to work a year supervised. And that's like a different pathway in terms of exams and all of that. So if you can take the QE1, it's way easier. Now, when they call a rural program here in Ontario for residency, it's not rural. It's like maybe 35, 40 minutes outside. I know I was just reading an article the other day that this year, 12 spots in the outlying catchment of Hamilton with McMaster went unfilled for family medicine. So I know there's a lot of smaller towns, maybe 40 minutes outside of these bigger urban centers that have residency programs. So you don't have to go like the middle of nowhere land. When I applied for residency, I did apply to like Churchill, Manitoba. I applied to one like in Nunavut because I was just trying to maximize my opportunities, and whatever happened. But there are opportunities and residency spots here in Canada that don't warrant you having to move, 25 hours away from your family.
Perfect. And this was the last question that we had just sort of on our agenda before we open it up to any other questions. And that's just a general, any other advice that you have for Canadian med students? Just generally, Dr. Khan, do you want to, any
Sure.
parting words of wisdom?
Yeah. I feel like don't be afraid to ask people who've gone through it before questions, because we can always give you insight and advice. Like, I am very open to people asking me all about my experience and what I did and how I came back. I've actually had people who just saw my LinkedIn profile and I've never met them and don't know anything about them, and they were asking me how the process was of going to UMHS and coming back to Canada, and I am very willing to tell people exactly what I did so that they can do whatever they need to do to come back as well. So
Perfect. And Dr. Bremner, do you have advice for current med students at UMHS or other Caribbean medical schools?
Just kind of in keeping what Dr. Khan said, you can't do this alone. And like every step I took to try to get my license here in Ontario, like I had no clue what I was doing. It's not like there's a checklist somewhere where you can just all of a sudden like start at the top and work your way down. I would just kind of do a little bit and then I would hit one roadblock and then I would figure out, okay, well, how am I going to get over this? And then do a little bit more and then hit another roadblock. So I actually put together like a big long checklist of everything that you have to do. And the physician recruiter with the healthcare corporation I work for, I actually gave it to her and she's kind of been distributing it to prospective residents that are in the States that are wanting to come back home. So I've talked to a few people on the phone because the weird, like the scariest thing is like, how do I do all of this? And to try to get on the phone and call the CPSO, you're going to be on hold for like 55 minutes. So don't be afraid to reach out to people because someone else has gone through this before and we're more than willing to help because you need like that network of people to help you. And that's also how you kind of get into different areas. Like for instance, with residencies, it's a lot of networking, just also maximizing opportunities for yourself, like be eager, try out different things, go in with an open mind. Like, yeah, maybe you do not want to do surgery, but just go into the rotation trying to take something away from it because for instance, I knew I didn't want to be a surgeon, but I want to understand what you do in a surgery so you can explain that to your patient because if they're scared and they're going for something, you can sit them down and see like, hey, like this is what's going to happen because the surgeons don't have the time to spend at the bedside and do that kind of stuff. So you're kind of just advocating for your patient and you can take something away from every opportunity that you're in, whether it's what you want to do at the end of the day or not.
Perfect. Thank you. At this point, we're just going to open it up to any other questions that we might not have addressed in the chat. We tried to monitor the questions as best as we could as they were coming through. And both Dr. Bremner and Dr. Khan have agreed to share their LinkedIn contact information, which we will be dropping into the chat. So if you have specific questions for them, if you're looking for their input or their advice, they've graciously agreed to share that contact information with you so that you can reach out to both of them. So we've got another question here in the chat. I'm hearing that the U.S. residency positions require 100 hours a week. Is that true? Would one of you like to take that one on?
I can.
Okay, great.
The cap is 80 hours a week. So, and that's just a cap, right? So there were times that we were doing 80 hours a week, and that's on an average. So it's like a rolling average for 2 weeks. So you will have days where you don't work at all, and you will have weeks where you work a whole lot, but it's not constantly 80 hours a week throughout every rotation that you do.
Perfect. Was that your experience as well, Dr. Bremner?
So when you look at the verbiage, it's 80 hours average over a 4-week. Like you're not supposed to go beyond 80 hours or more than 24 hours at a time, but that's only when you're considered like truly on call. There are some times where our night float was half of our inpatient weeks was during the day and then half of it was night float. So those were only on average maybe about 14-ish hour shifts. But then if you had like history and physicals to finish or like progress notes, then you might be there a little bit later, but that's not included in that hour count. And then we did 24-hour call. So of course, there were times during COVID that to hand over 12 intubated patients is going to take forever. So there were times that I was there beyond the 24 hours, but as you progress, particularly in your third year of residency, the amount of time that you're working is far less than in your first and second year. So it does get better. I promise. It's a very busy time, but every hour that you're with there and you're with patients, you're learning something. So.
Perfect. Thank you. Let's see. I'm looking to see if there are any other questions that we might have missed in the chat. And it looks like I think we've covered just about everything. So Dr. Bremner, Dr. Khan, I just want to thank you both for taking time out of your very busy schedules to talk tonight and answer these questions, and also to share your contact information with people that might have additional follow-up questions for you. So thank you both very much. And thanks to everyone who tuned in. We appreciate your interest.